Hey, it's Patty. In this presentation, I'm going to talk about just general dysautonomia treatment. I have another presentation on dysautonomia, like the general presentation, which is really important to go along with this presentation as well, because we really need to understand where dysautonomia is coming from. But even in that presentation and this one, we're not breaking it down into specifics yet, because there's so much to talk about between the presentation and also the treatment, and I really try to keep it an hour or under. So this really is general. This is like an overview with little things sprinkled in, and then hopefully we'll get to specifics of a lot of the stuff that I'm talking about over time for sure. And the first thing I want to talk about and clear the air with, because it's not my specialty, is to talk about pharmaceuticals. And again, there's so many different strategies to treat dysautonomia. Pharmaceuticals is one, and it's very appropriate for symptom management. A lot of the other stuff I'm going to talk about is for long-term management as well, or flare-up management and things like that. But there are many individuals that, especially at the start of their journey and trying to figure out how to stabilize their autonomic nervous system, that pharmaceuticals are very appropriate. We would hope that, through understanding where the dysautonomia comes from for the individual and how to treat that part, and then how to retrain. And we'll talk about some of the other strategies in here and then in other sessions as well. That hopefully these are temporary to help reset the system while we work on those long-term strategies. That's what we're hoping for most people. It's not necessarily what happens for everybody, but that is kind of the long-term strategy, is pharmaceutically treating in a temporary phase while we work on the other things that we'll talk about. But this chart here is just informational for those of you that are wondering why they prescribe certain things to certain people. There is a method to the madness in understanding what the certain medication does. And if you have watched, and if you haven't, please go watch the general dysautonomia presentation. That's about an hour long, because it is important to understand that dysautonomia shows up in many shapes and forms because it does innervate all of the organs of the body. So how it's going to affect blood pressure and heart rate is just different for everybody, depending on what part of their system is aggravated, and along with different anatomy as well. So we want to make sure that we're treating the appropriate output of the dysautonomia, the appropriate symptoms that we're seeing based on the individual. And there are actually medications that we can break down to say, this individual might do better with beta blockers because they do have really that rapid heart rate, and that's the primary symptom that they're having. But we also might have somebody that really has low blood pressure and brain fog, and they might be more appropriate for stimulants. So this is really something that needs to be talked about and looked at with a professional that understands dysautonomia and how it pops up and when certain medications are appropriate for certain presentations. So the overall look at the holistic management of the autonomic nervous system, like what are the things that we can do, that we have access to as providers or individuals that are dealing with it. And there are things that can help monitor the autonomic nervous system now out there. There's heart rate and blood pressure apps that really you can get the feedback that it gives you to be able to adjust your daily activity or your exercise output accordingly, so that we don't have the boom or bust cycles that we tend to have. It can give you a little heads up that, hey, your heart rate is a little bit off today. Maybe we don't want to do that long run that we were planning. Or your heart rate is off today. Maybe we have more horizontal breaks. So we can monitor it, and through monitoring it, we can figure out how we might need to retrain it, and especially on what days might be most appropriate to really put more effort into retraining the system. And then heart rate variability. So heart rate variability is the measure of kind of the sympathetics and the parasympathetics and how they're appropriately responding to our body's activity. And heart rate variability is, we should have heart rate variability. There should be a difference. So it looks at actually inhalation and exhalation with the heart rate, because as we inhale, there's actually a sympathetic response, and as we exhale, there's a parasympathetic response. So we should have an increased heart rate during the inhale and a little bit of a decreased heart rate between the exhale. So they look at the spikes of the heart rate compared to the breath rate, and we should be seeing increase, decrease, increase, decrease. So we should have heart rate variability, right? So if we're not seeing the variability, if we're seeing very regular intervals and the breath is not changing anything, then we know that we're not in sync with what's happening. Our sympathetics and our parasympathetics are actually not coordinating through multiple systems. So it's a reflection of the coordination of our autonomic nervous system. So the more variability we have, the more communication we have that's appropriate between the systems. So those can help monitor, it gives you a little cross-reference between two systems of how the autonomic nervous system may be responding. And that's heart rate variability is something that's talked about a lot with dysautonomia and the autonomic nervous system, because it's one of the most accessible tools that we have for individuals to use on their own at home now. So it is a great tool in measurement. Are they very precise? No, but they can be very helpful. And it really depends on what app you have, if you have a ring versus a little heart monitor. But there are a number of different things out there, and it can give you the same information that we were just talking about with even the in the moment heart rate and blood pressure. It could tell you those days when we might not have the best communication between our sympathetic and parasympathetic. And those are the days that we don't necessarily want to challenge the communication because it's already not working that well. So those are the days again that we don't push workouts or, we don't push vertical time and things like that because we know that the communication isn't going to be that efficient. So those are the days that we actually want to help the communication rather than strain it. Adjusting position and activity. This is one of my favorite things to do with people. And what we have to remember is, and I like to change the language a little bit, when we're talking about dysautonomia, really the long-term goal is to retrain the autonomic nervous system to work appropriately for what we're doing. And we'll talk about that a little bit as we go into exercise programs and things like that, all the protocols that are out there. Well, we want to make sure that it's responding appropriately for exercise, right? Like we don't want to just jump into something if we're not even standing with a normalized response. So these supine breaks, these horizontal breaks, it's just retraining. It's an exercise for the nervous system that when we go down into horizontal, that those are 10 minutes where we're telling the system, okay, now go ahead and turn your parasympathetics on. Everything's fine. We're safe. The body can relax. We don't have to pump against gravity. And then after 10 minutes, you get up and you say, okay, it's time for the sympathetics to start working. So it's just retraining the system. And especially in the beginning, it's a really good idea to plan this in every 90 minutes to 2 hours or so. What happens for a lot of people is they do lie down. And that's what I hear a lot. Well, I do lie down. If you're already to the point where your system has crashed and you need to lie down because you can't go on any further, you're only in recovery mode. You're not in retraining mode. So it's not an exercise anymore. We're not ahead of the game. We're actually just trying to recover from what's been done. So that's not therapeutic at that point. So if we plan it before we have a crash and burn moment, now we're retraining. Now this is an exercise. Now we're staying ahead of things and we're using it as an exercise for the system to remember what it's supposed to be doing. So that's why planning them a lot more beneficial in the beginning of somebody trying to retrain their nervous system. And maybe you can wean off of that over time for sure. And then avoiding repetitive transitions, so up and down motions, even if we're thinking like physical therapy exercises, sometimes just like squats going up and down, that repetitive motion and the body constantly trying to figure out what it's supposed to be doing with blood flow in those positions. If you don't have good communication, it's going to get confused and it might get angry and it might say that it doesn't want to do it anymore and you can have a dysautonomia event, right? So in for those that are just working to start to retrain their system, we don't necessarily want these changes in positions, And again, I'm in the physical therapy world, so I've seen this a lot, especially when I was starting out my career. And I did this with people as well, and maybe not with dysautonomia, but I just think back and I'm like, oh my goodness, there's so many other things that we could have done even just to make the session itself better and avoiding, okay, we'll go ahead and lie down. Let's do your stretches. Okay, sit up. Now we're going to do something at the edge of the table. Lie down. Let's do an exercise. Okay, come off of the table. Let's go over here. Let's lie down over here. So making sure that they're not constantly switching and transitioning positions. core exercise and activity can be very helpful. So we try to do all of the vertical stuff in one period if we can, and then we do our horizontal things in one section so that we don't constantly challenge the system. And then what we're going to talk about a lot is treating the autonomic nervous system. And this has to be done with each person that has dysautonomia. We can do the superficial treatments and the pharmaceutical treatments, but we actually have to treat the autonomic nervous system at some point. We have to help rehab the nervous system and retrain it to respond appropriately. And it's really like we're talking about food, nutrition, and diet. This is very different for each person, and it does take a little bit of experimentation and on the patient's part too, intuition. What might feel good to you? What might you have heard good things about? What would you like to try? So that's really a rabbit hole. We'll get into a little bit of that today for sure. Okay, so here's common recommendations for POTS. I call this my superficial treatment, right? We're treating what we think works for the diagnosis. We're not yet treating the patient. And that's where I let patients and providers alike know, um, let's hear the negative responses as well. I think there's a lot of fear from the patient side of it that we're going to offend providers if something doesn't work. It can actually give us more information as to what's really going on. If you tell us, oh my gosh, I started taking the sodium and my headaches got worse. And that's great because it might tell us that you have an intracranial pressure problem. So don't feel bad about these superficial treatments not working. These treatments are made for the diagnosis itself, and we're so much more than a diagnosis and a label. We have so much more going on in our bodies. So again, superficial treatment, this seems to work for a lot of people that have dysautonomia, especially on the side of POTS. Okay, so and you always want to make sure that you talk to your provider, especially when we're talking about some of the sodium supplementations in here for sure. And I'll explain why as we get into that into a little bit more detail. But we talk about water and sodium a lot. We want to make sure that somebody is staying hydrated, and we want to make sure that somebody has a good electrolyte balance. And sodium is, I'd say the water and the sodium is really like nutrition for the neurological system. There's other things as well, but if we're talking about this autonomic regulation, there's also potassium and magnesium and things like that that are helpful. But sodium really seems to make an impact, right? Now, everybody's very different, but water intake usually between 64 and 80 ounces. This is great to work on with, somebody that's like a naturopath or a nutritionist or a dietitian. Sodium supplementation, especially as you get into that and you might be looking towards higher dosages, please work with somebody because there are recommendations in the literature of 3 to 10 grams of sodium per day of supplementation. So I'll get into that a little bit later, but that's a wide range and that goes up to a lot. And I think it's really confusing for people to know, well, if I have this diagnosis, what the heck am I supposed to be taking in? And again, it's really individualized, and that's important to know. So we'll get to that in a moment. Compression leggings. So compression leggings are what we recommend, but let's just say compression garments. I've had feedback from patients that they like the arm garments or they like the abdominal binders better, or they like the full body suits. Or, traditionally when we talk about these compression leggings, they are full toes closed, full leggings that come up to about the waist and belly button area to really help with the volume regulation in the legs. Those are hard to get on. They're hard to maintain and manage, especially in hotter weather. So just know everybody's a little bit different as to how they like the leggings and what they're actually going to wear. So compression in general can be very helpful for blood return. And what you find works for you may not work for somebody else, but there's a wide variety of compression options out there and within different financial ranges as well. So just something to look into. Not all compression garments are $300 pants, which I just saw recently, but they looked fascinating to me. Horizontal breaks throughout the day, like I said, that's one of my favorite ones to give people. And again, this is because this is where we're starting to retrain the system. The others are just supplementing the system so far, but now we're starting to retrain. We're putting input in with the horizontal breaks to try to retrain the safe space for parasympathetic when sympathetic is appropriate. So that can be very effective. Physical countermeasures for acute POT episodes. So we'll talk about that a little bit more, but basically that's when we're having a POTS episode, and especially if when we're transitioning positions, are there things that we can do to prepare the body to take a vertical position? Um, I know it might sound funny to the general population, but those with POTS are like, yes, yes, it's very difficult to go vertical sometimes. And preparing, getting the blood volume actually moving through the body can help prepare because again, we're talking about retraining the system, right? And sometimes if you give it a little bit of a boost, it turns on to the appropriate channel. The elevating the head of the bed to 30 degrees. So this is really to help reduce the toll on the kidneys overnight. So we use this with frequent urination, especially overnight. So what I tell people is, sure, you can do this one if you'd like to try it, but it's typically cinder blocks underneath the feet of the head of the bed because you want the whole bed angled at 30 degrees. You're not bent at the waist and propped up with pillows. Your mattress actually has to be at a 30-degree angle. So this can be difficult to set up, and some people feel like they're sliding down towards their feet. It's also one that once it's set up and you kind of walk away from it and then you can just experiment on it. It's not necessarily something that you have to do every day, right? Like you just get into bed. But that is something for my individuals that seem to have frequent urination overnight. It might be helpful. Um, and the last two, these are recommendations. I think these are the hardest two to do. And Tom and I are going to do a talk soon about that mindfulness and meditation, and we're going to reframe what that actually means because I know that that's triggering to a lot of people. Um, but I think if we understand the science behind what I think they're trying to say in strengthening the parasympathetic system, um, now it makes sense, right? And but that looks different for everybody. There's so many things that you can do for that. And then overtaxing the system with any additional stress. I just kind of laugh at this because this is one of the most important things for autonomic nervous system regulation and to help long-term management strategies in POTS and any other type of dysautonomia. And this is the most difficult one, removing stress from your environment. Some people are just stuck in it, and I understand that, and that's why these superficial things in pharmaceuticals are great. But I will tell you that that will have to be removed. You will have to figure out how to manage stress or remove it from your environment if you have a dysregulated autonomic nervous system that doesn't like to respond to that, right? And then again, I'm going to change the language in the last one. If you do encounter stress, having a system that has a strong parasympathetic presentation, a strong, robust parasympathetic response when needed, and you know, daily as well, then that could help with the stress response as well. These physical countermeasures, so this is anything that helps move the blood before going vertical because we have that pooling that happens and it's very hard for it to, depending on the individual, for the blood to come back up to the heart. So we get the blood moving before going vertical. Okay, so if somebody's been in a horizontal position, what we call supine lying down for a good period of time, trying some muscle pumping activities to move the blood before standing up can be helpful. And we do this from lying down to sitting, muscle pumping activity, and then eventually standing. And even in standing, we can do some muscle pumping before moving. So this is ankle pumps where we're just kind of flexing and extending the ankles up and down, squeezing the thighs in place, fist pumping, muscle squeezing or flexing anywhere in the body can be helpful to acclimate to different positions. Okay, I'm not going through all of this, but I thought this is a really good representation of how we treat POTS. And this is how it should be. You look at everything because the autonomic nervous system, as I talked about in the other general presentation, it talks to everything in the body. Okay, so yes, we have sodium and water, we have compression garments, all of these things. Iron supplementation is something in this article they recommend. Um, but there's so much that goes into this. Looking at the physical deconditioning that's happening, yes, it's something. Looking at the whole of the patient is just it's really important so that we're not just hyper focused on let's get that heart rate up or down, depending on the individual. There's a lot of things that we can be doing. So we should be looking at this from various different angles, not just a one treatment strategy and done. This dysautonomia nutrition, it's kind of like everything I talk about, right? I'm going to give you the information that is from the research that's out there, but especially nutrition. I'll have another presentation on this soon. Nutrition is extremely individualized, and this recommendation or these recommendations on the next couple of slides is really saying, hey, these things can pop up with dysautonomia, and we know with each one of these individual things, these things could be helpful. So I don't want people to think that if they have dysautonomia, or right, it's like some of the EDS protocols as well, that you have to take 50 different supplements. That's not what it is. It's more so, what are your issues you're having with dysautonomia, and could working on this be helpful for you? And I'll say, if you're working on nutrition with dysautonomia, then for this reason, you would definitely want to see a person to collaborate with, and hopefully a specialist, but at least to collaborate with to figure out the right combination. We know that with dysautonomia, the dysregulated autonomic nervous system, it can change motility, and motility changes in the gut can cause constipation, right? Um, Fiber can help with constipation. So again, we're still just putting the Band-Aid on it. We're not necessarily treating why the autonomic nervous system is mad and causing motility issues, but fiber can help things move. So again, really appropriate because we need bowels to move, right? When we're talking about reactions that cause bloating, diarrhea, and flatulence or gas, with certain things like IBS that are related to some of the dysautonomia presentations, low FODMAP diets have been shown to potentially be helpful. We know that especially with altered motility, we can have a buildup of bacteria, including the not great bacteria. So putting healthy probiotics in, and specifically they're talking about with diarrhea presentations, lactobacillus and bifidobacterium. Those two could be good strains to help support that. Prebiotics can help support gut health in general. For people that are having some motility issues, prebiotics, or it's not in this article, but prokinetics, as we call them, like artichoke and ginger, things like that, can also help gut health and stimulate digestion. Um, Again, back to the bacterial growth that tends to accumulate bad and good when we have slowed motility. Antioxidants and fiber can both promote healthy bacterial growth. And then just overall, preventing dysbiosis by eating healthy, right? And this is why I'm not a fan of going down the elimination rabbit hole with individuals and taking things out if we haven't just had the talk about just healthy eating, just getting rid of processed foods, inflammatory foods in the realm of things that are more contaminated, or again, the processed piece. Because when we talk about healthy food, there's actually a lot of healthy food out there, but everybody's going to have their own responses regarding inflammation. So it's really hard to do an anti-inflammatory diet. You got to work with a professional. But avoiding processed foods, refined carbs, and high salt, cured meats, artificial sweeteners, fructose, and alcohol is what this recommends for things being in your food, specifically. So the high salt in foods typically comes with processed foods. I know we're like, wait a second, we should be taking salt if we have dysautonomia. This is more high salt in processed foods. It's already coming in the food. It's a little bit different in how the body uses it. And then again, right, this is recommendations for all of the things, not all the recommendations for each person, but just ideas out there of things that they think with dysautonomia, certain symptoms could be helpful, like vitamin D, especially in the non-summer months. Vitamin C as well, which I know we talk about that with mast cell activation syndrome too. And then it's not uncommon to have vitamin B deficiencies when people have POTS, I've found. So maybe we supplement with certain vitamin Bs. But again, you don't just want to start taking lots of things. I really believe that precision is important, and as minimal as we can be is super helpful for connective tissue. So work with somebody, because there's a lot of vitamin Bs out there, but they recommend B1 and 12. in what they felt would be helpful to individuals. And then regarding fatigue that comes along with POTS, their recommendations was CoQ10, magnesium, and ADH, and alpha lipoic acid. Fatigue is very complicated and complex, and while those might be beneficial to some people, not for everybody, right? So again, I just wanted to present at least, hey, this is what's in the research. It's good research, and there's information on, again, all of the symptoms we seem to see. And if you have more fatigue versus other things, then maybe look into uh, these supplemental options. Okay, so looking at IV hydration, right? So there are some people that do get IV hydration, whether it's saline, lactated ringers, or they call them cocktails. You can get your own personalized mixed out there. And they did do some studies on this, and they did find that 2/3 of patients that had POTS in a hospital setting did require IV hydration. And what they got varied. And what I'll say from my experience is the varying is what's available and authorized, not necessarily what the patient needs. So this can be a little bit tricky. Um, Saline is typically it's saline. It's a little bit of sodium and water, right? Lactated ringer can come with different vitamins and minerals in it, and also you have the sodium in there as well. And then you can get the personalized ones where you can kind of add what you want. A lot of them do lactated ringers or Myers cocktails and things like that. What they're saying, though, is about the saline specifically, is that if you have blood volume issues, the saline might be appropriate for you, right? But not necessarily in salt loading. So IV saline might be helpful with blood volume problems. But if we're looking for the salt loading, then perhaps it's a lactated ringer or a personalized approach. There's not a lot of research on this, and there's so many different versions of POTS and dysautonomia out there. It would be hard to do, but we just don't have the research yet. What they do say is with the IV hydration methods, it's not recommended for long-term use. What a lot of individuals I know do is they'll kind of front load the larger or more frequent doses and then spread it out as they go along to see if they can kind of break the cycle. It might help patients that have medication resistant POTS. So for patients that are having difficulty finding the right medication, or like many of our individuals in our connective tissue group, they respond adversely to medications and they don't necessarily want to try more medications, and IV hydration is something to consider. There's also a high rate of complications, both deep vein thromboses and infection as well, with the more times that you poke veins, right? And again, just wanted to throw in the research. This is a little bit of crossover between mast cell nutrition and dysautonomia, but there was, and I'm not going to read through all of this, but the nerdy science is there for people that are wondering. Basically, the theory is that gluten, if somebody is irritated by gluten, and I'm not going to go into why that happens because there's actually a number of different reasons, including genetics and not, but can become irritated by eating gluten. And the inflammation process that happens when your body responds in a negative way to gluten can cause this neurological inflammatory process that irritates the autonomic nervous system. So again, it's that feedback loop that I've talked about with dysautonomia, that I've talked about with MCAS, is that this is something that stimulates the feedback loop, right? So like they were saying, that this could be more so an immune system type of response. And gluten is part of it, but there's a lot of different factors out there too. But perhaps if gluten is an issue for some people, removing gluten or reducing gluten might be helpful in stabilizing the neurological irritation from this inflammatory response that's happening. Okay, so we're going to dive a little bit deeper into sodium because I know this is typically what everybody talks about is, water and sodium. And it's just interesting because the recommendation within the US is 2,300 milligrams per day of sodium. And that's just with your food. So it's not supplementation or anything like that. That's just your baseline, what they recommend that is a healthy limit. However, when you look at the WHO recommendations or the World Health Organization, they actually recommend that it's just a kind of a more free approach, but considering the health of the nervous system and the fact that we're all a little bit different, right? Is that some people might need more sodium and nutrition for their nervous system than other people. Um, they actually have a recommendation of less than 5 grams, which is just under a teaspoon of salt per day. So that's a big difference. And it's just something to notice the discrepancies, but really to notice that these are general recommendations, and not individualized recommendations, right? And we have to know that our nervous system might need a little bit more nutrition, more sodium, water, potassium, magnesium, compared to somebody else's. Children, there isn't a specific with the WHO recommendations, there isn't a specific guideline for that, but it's just recommended that it be adjusted downward for ages 2 to 15 years. And that's based on their energy level requirements, right? Because we should be getting a little bit more salt if we're more active or if our nervous system is more active, right? Um, so there's no numbers for that, and there's nothing reflected for pediatrics, basically. There is a lot of research that's out there that supports intentional sodium supplementation with orthostatic intolerance. So we do have research support. And also, and I know there's people that ask this question, and we kind of have an answer, and we don't also, about, well, what happens if I take it long term? And in this one study, at least by Williams, which is the information on the next slide or two as well, it's great information in this article, that looking at 3 months of higher sodium supplementation did not seem to have effects on the supine, so lying down diastolic or arterial pressures, so blood pressures. It didn't have adverse effects at that 3-month marker with consistent increased sodium supplementation in patients that had vasovagal syncope or POTS specifically. And then people ask all the time too, well, POTS is, we're talking about heart rate, but what if I have high blood pressure? And then the question is, well, what kind of high blood pressure do you have? Do you have reactive sympathetic high blood pressure to movement and activity? Or is this constant high blood pressure? This is just the norm of your body. So there are recommendations for sodium supplementation, or I should say tests to do to see if somebody's appropriate for sodium supplementation in those that seem to have high blood pressure when they're vertical. So there are 24-hour urinary analysis for sodium excretion that can be done. So if patient wants to potentially experiment with sodium supplementation because they do have this POTS type reaction and also high blood pressure, these are the measurements that they look for with the sodium excretion in a safe range for individuals that are looking to go on to additional sodium. And also with the 24-hour urinary sodium excretion, we can also see lying down, what is your blood pressure? So lying down, if things are normalized and you have normal blood pressure, it's not high blood pressure, then that might be a sign that this is dysautonomia, and perhaps some nutrition for the nerves might be helpful. This is something that you absolutely want to be monitored by a medical professional, though. So definitely have to talk to a provider about testing and monitoring if sodium is considered in somebody with high blood pressure. But it's not a no. It just depends on the person. Interestingly, women might have a more favorable response to men when they increase their salt content. And this might be because there's this different peripheral vascular control. We have lower plasma volumes, lower blood pressures, and we also have a difference in the orthostatic vasoconstrictor responses. So the way that our nerves integrate with our blood vessels is a little bit different as to how they respond. So women or female-born population might do better with sodium supplementation. And like I said, I like this article because they go through a lot of different questions that do pop up. And interestingly, they did some research and they found that the Black population might have a higher orthostatic tolerance compared to white populations. So the Black population might be less likely to experience syncope, so passing out episodes, they might have more rapid increases in blood pressure and heart rate, traditionally on standing. So just something to watch out for providers or patients that are just curious. This might be inherently something that is there. And also, they are more likely to exhibit salt sensitivity. So this could be a population that we would want to go much slower with titration with the sodium. Okay, so talking about titration of the sodium, I know a lot of people have it in their heads that it's six, and it could be six for some people. Honestly, a lot of individuals that I've talked to, worked with, talked to other providers, we don't necessarily have to get up that high. And if it's getting up that high, they should be working with a medical professional and they should be monitoring their lab values for sure. But the recommendations are somewhere between 6 to 10 grams of sodium if you have dysautonomia. But that's overall. So if somebody's already getting in 3 grams with their diet, then we might only be looking at 3 grams of supplementation, which is actually still pretty significant. I'm not sure if anybody that's done the research has done the supplementation themselves to know what it feels like during a day, taking 3 grams or 6 grams of additional sodium and drinking or swallowing that much. It's a lot. It really is a lot. 6 grams overall throughout the day really should be enough to improve orthostatic intolerance and to improve symptoms for people. And this 6 to 10 gram range, this higher range, is really meant for either our more active individuals or on more active days during flare-ups, or as we're considering potentially going through some of these protocols of activity with them. So this is, or if they're not responding to the lower doses like we'd like to see. But this is, we typically don't have people in the higher ranges. That's much less frequent. So these lower ranges that people have, we can do a titration to work on that, right? So, there's no problem for most people starting at a very, very minimal place and slowly titrating upwards with no matter what we're talking about towards the recommended or the standard or the average dose, and seeing if they hit their own, limit or their own therapeutic dose before we think it should be the average, right? So a lot of these supplementations are anywhere from 250 to 500 milligrams when you have the electrolyte balance of sodium. And you can start at, if they're the capsules, 250 milligrams, you can start at one capsule and you can slowly increase over time to see how the body responds to it. And you can hang out at 1,000 for a little bit to see if you had some adverse symptoms, does it acclimate to it or does it not? So we don't necessarily have to jump into 3 grams, 6 grams. That's a little disconcerting for me when we're potentially dealing with other pressure systems and responses, is we really do want to try to take things low and slow. Okay, so there's no harm in starting lower and slowly titrating upwards to find somebody's therapeutic dose. But again, it's really important to at least hash ideas out with your medical professional, right? There's no data on table salt quality showing more efficacy. So I have a lot of people ask that question. Like, I'd really prefer not to spend hundreds of dollars every month on sodium supplementation. Can I just use table salt? Possibly. We don't know. It is important to note that that's sodium chloride. So typically, because there's less weight because it's two different molecules, sodium and chloride, that you're going to need a little bit more table salt if it's sodium chloride compared to the sodium that we're talking about in these electrolyte mixes. We do want to avoid higher salt intake in some patients. So I wouldn't say that these are complete contraindications, but these should absolutely be monitored and prescribed by medical practitioners if somebody has hyperaldosteronism, Cushing's disease, or Little syndrome. The conditions already cause more salt retention. So that can be a tricky area to try to put more salt in when somebody is already retaining more salt. And then this last little piece here is just talking about the relationship between glucose tolerance, insulin sensitivity, and the fact that actually those that need the sodium might have a positive insulin sensitivity response and improve glucose tolerance if we level out their sodium levels, if they've been lacking. So just another little note within that article from Williams. Okay, talking about movement strategies. So where do we start and where are we going if we're talking about dysautonomia? Well, we want to start easy and we want to progress to harder. That's kind of how it is with everything because we're trying to retrain the autonomic nervous system. So we have to start low and then work our way up. So the easier positions, and this is information from Heather Purdon that she puts together with some of her information in some of her classes. Easier means horizontal, lying down, or recumbent, lying down. Lower extremity stretching or strengthening and core strengthening. So more of the leg and core type of activities, low intensity or low RPE, rate of perceived exertion. So the individual says, I don't feel like I'm doing much. Great, we're just trying to retrain your system. Shorter intervals, which also means longer recovery in between, wearing compression clothing during activity, considering aquatic therapy as well, and even starting in a horizontal position, so lying down with the physical therapist. There's a lot of stuff you can do lying down in the water with support with flotations, with also that hydrostatic compression can be helpful for dysautonomia. And then controlling temperatures. Now, eventually, reteaching the system how to respond appropriately to temperatures is amazing, but we don't necessarily want people to start off with cold immersion baths yet when they're first starting out, right? So we've got to start slow and work our way up. It's a great goal and something to actually work into because we want to train somebody to do temperature regulation eventually. When we talk about harder strategies, so where is somebody working towards with movement and activity? Well, we want them to be in more vertical positions or to be able to change positions. Like I was talking about having people all over the clinic in different positions. Eventually, yes, that's not where we start. We want eventually to get to full body involvement. So not just singling out the legs or the core. We want legs, core, and arms to all work together in full body motion. We're working towards higher intensity or higher rate of perceived exertion. So eventually we can push people into more of that higher intensity type of training. Longer durations of workouts too, longer durations of movement or activity. We're not starting there. We can take away the compression garments over time to see if the body can start regulating the blood volume itself. And then working more land-based to take away that hydrostatic compression that happens and put them on land so that they have to deal with gravity and whatnot. And then the variable temperatures, like I said, that's actually a great thing to train towards. But we're not starting with cold immersion baths. We're starting with, maybe a shower that's just a little bit less than what we would think is comfortable. And for some people, that's like really hot and warm. So it might just be tepid. And then the next time in the shower, maybe it's a little bit less than tepid. And this doesn't have to be any more than 1 to 2 minutes of exposure. So all of these are progressions. We don't want to start out at the hardest possible version of whatever we're talking about. We actually want to work and integrate the system into it because we're trying to strengthen the parasympathetics. And you're going to do that not by making it angry and mad because it can't stabilize where you're trying to stabilize, but we do it through very low, repetitive, consistent work that slowly allows us to do more over time. So other dysautonomia treatments, we do have regulation through meditation, mindset, mindfulness, and that's where I'm excited to sit down and talk with Tom. Hopefully this weekend we'll get it out about what we're really talking about is strengthening the parasympathetic response. Okay, so a lot of us have a very strong sympathetic response reaction, and that's just kind of programmed to go off at all times. So what we need is we need to retrain the parasympathetic strength and consistency and frequency. And for some people, that is meditation, mindset, or mindfulness. For some people, breath work can also be helpful. I always say be cautious with breath work because with breath work, if you have a dysfunctional breathing pattern and we're not working on fixing that, you're going to continue to breathe with dysfunctional breathing through your breath work. So if you feel like you're in that scenario, I very much would like you to talk to somebody that does postural restoration, diaphragmatic work, um, therapeutic breath work in the idea of noting dysfunction and working on that. So um, that's why I understand why people get triggered by by these recommendations. But I think if we break it down and understand the science behind what we're trying to do and why it's not working for an individual, we can come up with much better strategies. Massage therapy with a trauma-informed therapist, especially if somebody has more intense sympathetic responses to touch, or if they just have a very heightened sympathetic response of the nervous system at the time. It is important to work with somebody that understands that putting their hands on you might cause a reaction, even if it's supposed to be something that is restorative. There are trauma-informed therapists that are out there. Acupuncture for some people, right? And this is like, as I'm talking through this, it's again kind of like food, diet, and nutrition. For some people, these are just offerings of what might be helpful to work on the autonomic nervous system and bringing it back into regulation. Cranial sacral therapy can help with that as well because it restores fluid balance and cranial and sacral mobility. So it can actually help regulate from an anatomical sense. There is some work by Stanley Rosenberg of his polyvagal resetting exercises. He has a book out there. It has some recommendations and then teaches individuals about the autonomic nervous system and the responses. So a few things that individuals can do at home. There are specific autonomic trained providers, and integrative manual therapy is one of the programs out there that has classes for the autonomic nervous system. Other programs out there are the Burrell Institute, and fascial counterstrain works on parts of the autonomic nervous system through spinal pathways. So there are other ones out there that are trained on physically working on the autonomic nervous system. Heart rate variability training, I talked about that a little bit before. Apps on phones, different programs, ring devices that read heart rate variability can be helpful for giving you feedback on how your training has been going. Cranial electrical stimulation, and this is something kind of like vagus nerve stimulation as well, similar to help rebalance neurological tissue and responses. Biofeedback, so this is a little bit more active. Biofeedback, you work with your heart rate, breath rate, skin conductance, and temperature depending on the unit that you're hooked up to. And this is kind of like the stories of the monks being able to raise their body temperature in freezing weather. You can control your autonomics. That's like bench pressing 1,000 pounds, right? But we don't necessarily need to do that. But talking about strengthening the parasympathetics and control, that's where we're trying to get to, is just normalizing responses, but it is possible. Frequency specific microcurrent, that's something I work with a lot. And I do think that helps for some people. It's got a lot of, there's a microcurrent or a frequency specifically for the vagus nerve and also for other cranial nerves and things that are associated with the autonomic nervous system that could be helpful if we put the right frequency pairs on it. Low energy neurofeedback systems are another one that is helping to regulate the vagal tone and the output of the nervous system. Vagus nerve stimulation, there's a lot of different units that are out there now, and that's what, so the cranial electrical stimulation is a type of vagus nerve stimulation, which you see the picture for. So you can have pads that go on the neck or clip onto the ears. A couple other units out there. I know there's a handheld vagus nerve stimulation. There's implants as well. A lot of different things that can stimulate the vagus nerve, right? Even humming, closing your ears off with your fingers and humming is one that they use in yoga. So vagus nerve stimulation in general, because that vagus nerve is a conductor of the parasympathetic response. So the more that we have that appropriately activated, the stronger your vagus nerve is, then the more likely we're going to have a nice, strong, healthy parasympathetic response. So anything for that can be helpful. Neurofeedback is another one where kind of like biofeedback, but for the neurological tissue. So you have electrodes that are hooked up to different parts of the brain, and it shows you which parts of the brain are working, and you have to work to really, it's kind of like that homeostasis, right? Like you shouldn't be just sitting here working on neurofeedback and your brain is having this sympathetic reaction and lighting up these different parts of the brain. So it retrains you how to communicate more appropriately internally in the brain with certain scenarios. Emotional behavioral therapies. So there is that cyclical relationship between psychology and neurology. They can both influence each other. So for those that have dysautonomia, if there is an emotional dysregulation component, that can be very helpful for that part of the cycle to help balance them out, right? Energetic therapies are some people out there that really like Reiki, polarity therapy, healing touch therapy, so many different types out there, so many different names for it. Energetics, if you want to try it and you're afraid to take the step into it, it's frequency is what it is. It's a type of frequency modality. It's just through manual application. So there is some science behind it. Some people really like it. It tends to be very calming for the nervous system. And then we have top-down approaches. And I will say top-down approaches, um, the retraining of your nervous system, like actually rewiring. So if somebody has blown a fuse and the breaker box is off, we need to turn the breaker box back on from the source, right? And I feel like a lot of these other things are really just checking outlets and making sure everything's working. From what I've seen, the most benefit in my individuals is those that work on all of these nervous system regulation stuff. You can even do emotional and behavioral therapy, but retraining the wiring of the brain is different. Okay. So finding something that works for you it's very, very different. I'll do a whole nother talk on this at some point. It can be as simple as we're talking about that strengthening that parasympathetic response, right? Training the body how, nope, this is natural, this is normal, you're supposed to turn on all the time for me. This is where we're supposed to be. We're not supposed to be in fight or flight. So having those moments of just sitting down and envisioning happiness and joy and all of those feelings that come with the safe space of your parasympathetics, and that can sound very difficult for people. So there are programs out there like DNRS, Gupta program, Primal Trust to get you into a better mindset with tasks and homework for you to go through of basically how to reset your brain. But I think this is really important if we're talking long-term treatment strategies. These are all really good, all the things that we've talked about. But you're going to have to retrain your brain long term. So the output coming from the brain to the autonomic nervous system is also regulated, and then the autonomic nervous system to the body. So again, it looks different for everybody. There's so many different techniques out there. Yes, mindfulness and meditation are some of them, but they don't work for some people. So really trying to find somebody that specializes in autonomic regulation is very helpful. And I know it's very hard to find, but there are individuals out there. They could even label themselves as like mind, body, spirit practitioners. It really depends on the person and their understanding of the autonomic nervous system and how to reset it. But there are these programs that are available online to start the process of understanding what the retraining of the pathways might look like from like a holistic point of view, right? And then eventually, look, I haven't talked about it yet, and I know that everybody does. Eventually, aerobic training for long-term management. I know we talked about this a lot. Like the Levine, the CHOP protocol, there's also the ADAPT protocol. Forgot to put that in there, I apologize, but the ADAPT protocol is another one as well. And they've come out with a new version of the CHOP recently too. So I do think that aerobic training can be helpful, but in my personal point of view is that I would like to regulate your nervous system response first and then consider aerobic later. Aerobic is actually very hard to maintain if your sympathetic and parasympathetic aren't communicating, or getting into some of these aerobic programs and having part of that parasympathetic strengthening as part of it. So, in other words, if you are doing a short bike workout as part of like your hit part, your intense part of your workout, this little bike type of response to see, can we get your sympathetics up? And then can you lie down for 10 minutes afterwards to remind your body that the workout is over? And that's what some people have difficulty with these protocols, is that nothing reminds your body that it's supposed to come down into a parasympathetic state after, right? So anything that we have in our toolbox that does that for the individual would be helpful while starting these programs. I'll phrase it that way. I think they can be extremely beneficial. Anything that's training you to get back to activity when we're dealing with altered nervous systems is really beneficial, but we need a normalized response first so that we can actually get you started in the program. So can we train it at the same time? Can we have these supine rest breaks or more supine type of or lying down type of workouts first? And if nothing's working, we have to remember that the autonomic nervous system comes from the brain and the brainstem into the rest of the body. So what might be irritating those things? Well, a lot of things, right? So for frustrating um, or presentations that aren't really responding to anything, we've really tried all of it. Heck, you've even tried all of that neural retraining, and you are a happy person and you really can get there, and you've tried everything, right? Then the other things that we have to remember that could influence brainstem irritation is mast cell activation syndrome, upper cervical instability, Chiari malformation or brainstem adhesions, changes in intracranial pressure, so the pressure changes inside of the head, CSF leaks, cerebrospinal fluid leaks that happen in the cranium as well. Eagle syndrome, which is compression of the jugular vein or even the nerves in there, so the neurovascular bundle in the front corner of the neck, vascular compressions elsewhere in the body, anything really at the brainstem, right? But even vascular compressions, what it does is that are happening elsewhere in the body, they change on the feedback loop that's happening to the autonomic nervous system because our blood vessel tone is regulated by the autonomic nervous system. Very important to understand for those that have multiple compressions. Talk about it at another time, but this is a feedback loop, right? So remember the tone, the amount of floppiness in vessels is dictated by the state of the autonomic nervous system. So for those with multiple vascular compressions, you better be working on your autonomic nervous system as a treatment plan as well. Um, but again, there are some that, and I'm not saying that everybody is 100% curable by working on nervous system regulation. But what it does is we clear up all the things that are too loud in the body that should be quiet or more precise in its language. And we see what's left underneath, because somebody really can truly have a May-Turner syndrome or truly have a Moll's presentation. And that is the thorn, as I call it, in the tiger's paw that has been really aggravating everything else and makes it look like everything is happening. So we don't want to miss those as well. And this is not necessarily, as I list these, it's not to say, oh my gosh, if somebody has dysautonomia, then they definitely have all of these things. No, not necessarily. And even with all of these things, a lot of these are very treatable, especially if we have the combinations that are happening together, because working on mast cells and the autonomic nervous system can really help down regulate those pain responses that are happening and make it a lot more clear as to what needs further treatment versus something that we can stabilize through a lot of these therapeutic means. And it's typically that we can, if we understand how all of these are connected together. So in summary, um, really just the first part, right? Treatment should be individualized based on the presentation. Everybody is so different, whether we're talking about pharmaceuticals, whether we're talking about all the strategies I listed, it may or may not work for you. I'm sorry, that's the way that medicine actually is for just about everything that's out there, even the holistic stuff. And it's unfortunate because there's a lot of things that do work in the holistic field for individuals, with dysautonomia and autonomic nervous system regulation and some of those different treatments like neurofeedback and transcranial magnetic stimulation and things like that that are slow to be accepted by insurance companies. So there tends to be a good deal of out-of-pocket expenses. So I understand that it's unfortunate because also you have to experiment to see what works for you and your system. So I do know the frustration and the financial component of it. But pharmaceuticals can help manage those symptoms that are difficult to control and they're affecting everyday tasks, right? So pharmaceuticals can be helpful for symptom management, but when we're thinking about long-term strategies, we really want to discuss this and explore it with somebody that can help figure out what's helpful for the individual. And again, there's so many things that go to why we're experiencing dysautonomia and then ways to retrain the autonomic nervous system to help re-regulate itself. That we need to bounce these ideas off of somebody that has a lot of options, right? And then there's a typical approach to working with dysautonomia. I call that the superficial treatment. So yes, electrolyte balance, staying hydrated, use compression to get the blood back up to the heart or active motion, those ankle and hand pumps. And then retraining the autonomic nervous system. And that's really important. I'll emphasize that again. Eventually, we have to retrain our autonomic nervous system to work for us when needed. And that's really when I say that, I don't think any of us need training in the sympathetic type of response. I have had some people that do actually, but most of us need more of a parasympathetic um, type of retraining. So getting us more into a stronger parasympathetic state. And that's where things like meditation and mindfulness are brought up. But please understand it's a world of other things to do, to try, and to get help with. Okay. So that's where the long-term management is going to happen is figuring out why you had dysautonomia and then retraining the nervous system while working on all of these adjunct therapies and supports that can help reset the system. And then we have lots of references just in case anybody wanted to look anything up from the slides that were provided. So thanks for hanging in there. I know it's another long one. I feel like everything I do is really long, but we'll get shorter as we break things down over time and talk about more specifics. But again, general overview, little pieces here and there. Hopefully you understand there's actually more options, which for a lot of people I understand is more confusing. But I always see that as a positive. If we have more options, we have more things still to try if you feel like things haven't worked for you before. So hopefully this will give everybody a little bit information, patients and providers alike, about maybe some different things to try that maybe somebody hasn't before, different avenues to go down. All right, thanks for hanging in there for this one. See you next time.